Hello, I'm Sarah Carberry, and along with my partner in crime, Mary-Beth Casey, we came together to improve organisational systems within the community setting. We bring a unique combination of perspectives to this study, as I come from an administration background and Mary-Beth from a clinical practice. The purpose of this video is to walk you through the patient portal appointment scheduling system, which is a digital transformation solution that empowers patients and reduces workloads. The system automates the scheduling of patients from a multiple of referral sources. We are confident that this system will solve the major issues surrounding the patient referral and scheduling that exist in the community setting. Throughout this video, we will be taking you through the steps and the hurdles that we overcame to get this project off the ground. In our initial research, we identified 3 key issues in urgent need of improvement: high DNA, CNA rates, staff time and money wastage, poor management of patient data. While researching the DNA, CNA rates for each discipline, we calculated that for the Ballymun network alone, the DNA rates ranged from 20 to 40% across all disciplines, with an average of 24%. The impact of these percentages on patients is longer waiting lists, which can lead to the deterioration of the patient's condition. Also, patients become stressed and angry at the difficulties of accessing our services. Waiting times can be months and even years for some services. From an organisational perspective, it's estimated to cost the HSE nationally approximately 19.6 million annually. There are an unnecessary number of platforms housing patient information in order to generate an appointment. The same patient data is being entered manually onto 4 different platforms between 2 separate departments. Since these platforms are not interoperable, the information is housed and siloed on outdated software. This constitutes a possible data record retention and GDPR breach. Researching appointment scheduling systems indicated that when patients are empowered to select the date and time of their appointments, attendance rates would increase by up to 53%. If 2 additional reminders are added, this can further increase attendance by 19%, bringing a total reduction of DNAs up to 72%. This would equate to an additional 299 patients seen in 2019 and 182 additional patients seen in 2020. This reduction of DNAs was a key component in the selection of a patient portal appointment scheduling system. The PAS system was a good solution, but we needed to get approval from management. We pitched the idea to local management team and the Digital Solutions Board in July 2020. Locally, it was decided that we were going to introduce PAS as a proof of concept in the Ballymun Learning site for physiotherapy services. We had informative conversations with all clinicians and key admin staff working within this service. In October 2020, Martin Curley, the project sponsor, introduced us to Aileen Killeen, who works in the office of the Chief Officer. By late October, Aileen and an additional 2 external consultants were brought in to assist with the formation of the working groups, the steering group, and the initial project documentation for the PAS. Now that all key decision makers and senior management were on board, it was time to begin organising the workshops to map out the current process. At the as-is workshops, we met the key stakeholders and documented how referrals are received and outlined the risks associated. Referrals are received from multiple sources such as GPs, hospitals, allied health professionals, voluntary agencies, and self-referrals. There is a 6-pager PCT referral form, but referrals are received in various formats and all providing different information. The Central Referrals Office scans and types referral details into the SoftGo platform. The referral is scanned over to the relevant admin staff and clinicians. At this time, the admin staff manually enter all information onto the Reflections platform and then onto the Excel spreadsheet. If a paper file is pre-existing, it shows up on the Reflections platform and can be retrieved and given to the clinician. If the file does not exist, a new paper file is created. When the clinician reviews the paper file, the patients are assigned priority level. The admin staff update this information on the Excel spreadsheet. Patients are held on waiting lists in chronological order and priority ranking. The admin staff will issue a letter dictating the date and time of the appointment to the patient. From referral to appointment generation, this process takes up to 18 minutes per referral entry. There is no true data governance as only information stored on the Excel spreadsheet is whether the case is opened or closed. There is no electronic process in place for capturing follow-ups or discharge information. The key performance indicators are manually counted and collated. This time will be better spent with patients. With all the risks and processes recorded, it was vital that we work closely with key stakeholders and the selected vendor to address all the problems outlined, and thus the 2B workshops were scheduled.
At the 2B workshop, a digital solution was designed to empower the patient by allowing them to select an appointment date and time to suit their needs and to mitigate the risks identified. It became clear that a new primary care referral form was in an electronic format was essential for project progression. In the new system, patients and referral sources will receive an acknowledgement of either approval or rejection to the physiotherapy service at the time of triage. As the PAS will have referrals entered onto a singular platform, this will greatly reduce the amount of time between when a referral is received and when the case is reviewed by the clinician. Once the priority level is assigned, the patient information will be moved directly to the waiting list without any manual re-entry. Automatic communications are sent to routine patients, advising them they will remain on the waiting list until 6 weeks prior to their appointment, at which time they will be sent a link prompting them to select an appointment date and time based on parameters set by the clinician, whereas urgent patients will receive their link at the time of prioritization by the clinician. 2 reminders will be sent to the patient during the appointment and scheduling phase of the process, which will provide the patient with an opportunity to cancel and reschedule as needed. As clinician calendars will be housed on PAS, all follow-up appointments can be scheduled and information updated on the system. When the patient are discharged, basic discharge letters will be provided to all referral sources. Additional information can be included where appropriate. With all information stored on the PAS system, KPI data can be run at a moment's notice. With all risks addressed, a tried and trusted vendor was approached to provide a digital solution for the PAS. SwiftQ was selected to provide us with a pilot for the PAS solution. After many meetings and communications with them, we were able to determine that all the desired elements could be met. The future process has been outlined in the diagram on screen. As is very evident, the communications between the PAS, the patient, and the referral sources are greatly enhanced. While developing the 2B process, we identified the functional and non-functional requirements. These were provided to the business architecture team, ultimately leading to the creation of the statement of works. This, along with IT systems documents, formed the basis of the contract, as is required for the issuing of a purchase order. Voluntary, allied, and self-referrals log directly onto the SwiftQ platform to complete an electronic referral form. As the majority of referrals from community services are provided by GPs, it was necessary for SwiftQ to be interoperable with the HL7 standard utilised by HealthLink. Having reached agreement with the key stakeholders and the vendor on what the PAS solution would include, it was vital to progress the electronic referral form. The current paper referral form was updated and drafted in a new electronic format. Information required was broken down into general demographic data, children's information, and discipline-specific questions necessary for triage. We reviewed and amended this draft and eliminated any information that was not necessary. We then circulated the draft form to the physiotherapy heads of discipline, and on their approval, we circulated to all heads of discipline across the CHO for approval of the general and children's sections. We also sought input from the individual health identifier team, who added questions necessary for the verification of the patient IHI number. Data protection and GDPR gave direction on what was required to ensure electronic consent was valid. Data Dictionary were consulted to ensure metadata was compliant with the HSE standards. SNOMED was approached to ensure that clinical terms are in line with international standards. HSE Communications Department verified the self-referral form for comprehension and ease of use by patients. This is when we tested the self-referral form on a cohort of 20 patients from a variety of backgrounds, ages, and English language fluency. Minor changes were made to the form to make it more user-friendly. With our finalised forms signed off at local level, we recontacted HealthLink to have our forms hosted on their platform. We are currently on a 9-month waiting list to have access to the HL7 platform. Throughout the progression of the PAS solution, several other work streams emerged and were progressed in the background. On screen, you can see an overview of some of the work involved with updating the street listing, developing a DNA-CNA procedure, automating KPI and operational reports, and arranging for legacy data transfer. Regarding same, permission to access reflections on SOFCO has been requested from the OOCIO, and we are awaiting approval for same. We were required to complete a multitude of documents and templates. From first contact in July 2020 to local completion of documents required by the OOCIO, it has taken 10 months. In our project plan, we did not anticipate this significant investment of time. It was extraordinary due to the pandemic. As you can see, in terms of stakeholder engagement, we have collaborated with a myriad of agencies, external, internal HSE, OOCIO departments, as well as the patients and SwiftQ. GP referrals on HealthLink are unidirectional from the GP to the hospital. What is required by the PAS is a pathway from the GP to community services, hosting the e-referral designed to meet triage requirements of the PCT disciplines. The cost of developing, licensing and implementing the PAS for 1 year for physiotherapy is €24,800. This slide demonstrates that irrespective of development costs and licensing fees, the PAS offers value for money. Automated appointment generation costs 90% less than the system currently in place. This figure is calculated based on clerical, clinical and postage savings. Our next step is to roll out this system for all disciplines within CH09, which would have an annual saving of €170,000. Nationally, the estimated number of primary care referrals received are in the region of 550,000 for all disciplines. This is costing the HSE an estimated 4.5 million per annum with the current processes in place. Introducing PAS nationally will have an estimated cost of 790,000 per annum. This is a saving of 83% or €3.7 million. This slideshow has provided you with a whistle-stop tour of the PAS system. As you can see from the word cloud, there are a large number of benefits that directly impact the patients, staff, and the organisation as a whole. In conclusion, not only will PAS save the HSE annually in terms of finance, but it will also improve efficiency, governance, patient satisfaction, and health outcomes.